Critical Point presents an educational activity on metabolic acidosis. On a daily basis, our cells produce up to 100 millimoles per day of hydrogen ion into the extracellular fluid from three main metabolic processes. Firstly, the anaerobic metabolism of macronutrients. Secondly, the production of urea from amino nitrogen. And thirdly, the dissociation of carbonic acid formed from carbon dioxide derived from the aerobic metabolism of nutrients, according to this equation depicted. Despite this massive production of hydrogen ions on a daily basis, the actual hydrogen concentration of extracellular fluid is held at a tiny fraction of that produced. And this allows the pH of the body to stay close to 7.4 through several important physiological mechanisms. Firstly, through the normal expiration of carbon dioxide via the lungs. Secondly, because the renal tubules secrete hydrogen ions into urine, acidifying it and allowing hydrogen ions to be lost to the body. And thirdly, through various buffering processes which reduce the activity of the hydrogen ions. And in extracellular fluid, this is mainly the carbon dioxide bicarbonate buffer system along with hemoglobin, which also buffers. Secondly, in the intracellular compartment, it's mainly bicarbonate again, along with proteins and phosphate, which also act as buffers. The renal system also acts in the buffering system because renal tubules reclaim and regenerate bicarbonate, allowing the body to maintain adequate buffering activity. Now, it's important to notice that buffers don't actually remove acid from the body. What they do is they act to minimize the change in pH that occurs as a result of the concentration of hydrogen ions. It is essential that acid-base homeostasis is maintained in a very narrow physiological range. And this is generally regarded as 7.35 to 7.45 as the normal reference range for human pH. This homeostasis is essential for optimizing several biological processes, including the action of enzymes, the oxygenation of blood, and maintaining the normal ionization status of many essential biomolecules. In fact, the survivable pH range is wider than this, and the extremes of pH that are regarded as survivable are 6.8 on the acidosis end of the spectrum and up to an extreme of 8 on the alkalosis end of the spectrum, with 7.4 being regarded as the midpoint of normal. This is equivalent to a hydrogen ion concentration of roughly 40 nanomoles per liter. A pH of 7 is equivalent to a hydrogen ion concentration of 100 nanomoles per liter, and a pH of 8 equivalent to a hydrogen ion concentration of 10 nanomoles per liter. So a pH change of only 1 unit represents a 10-fold change in the hydrogen ion concentration, because pH is the negative log to the base 10 of hydrogen ion concentration. So the way that pH is notated makes a very large change in hydrogen ion concentration seem very small. So pathological changes of 0.3 or 0.4 pH units, which occurs commonly in clinical practice, represent at least a doubling of the hydrogen ion concentrations. Now, acid-base disturbances, and in particular acidosis, is common in various medical conditions. Metabolic acidosis is a sign of an underlying pathology. It itself is not the pathology. So if we regard a pH of 7.35 as the lower end of normal pH, anything below that represents acidemia, which is an acidification of the serum itself. There are various kinds of acidosis that can lead to this overall acidemic state. There are four main mechanisms by which metabolic acidosis can occur. The first one is there can be an increase in acid production. Secondly, a decrease in excretion of hydrogen ions or other acidic ions. Thirdly, the ingestion of an acid or a substance which is metabolized to an acid. And this does not have to be oral or enteral ingestion. It can also include the injection or infusion of intravenous drugs which are metabolized to acids. And fourthly, the loss of bicarbonate. And this can occur via two mechanisms, through the gastrointestinal tract or renally. So in the first three mechanisms, the metabolic acidosis results from a net gain in acid in the system. The fourth mechanism is a net loss of base. Even in the mechanisms where there is a net gain in acid, bicarbonate will be used to buffer this excess acid, and this occurs faster than the bicarbonate can be generated or reclaimed. And in cases where the problem is a net loss of base, the bicarbonate is lost faster than it can be generated or reclaimed. As a result, in metabolic acidosis, the primary disorder that you see on a blood chemistry panel is low bicarbonate. And if you're looking at a blood gas panel, the equivalent is a base deficit or a negative base excess measurement. So to determine which of these four mechanisms is causing the metabolic acidosis, whether it's due to acid gain or bicarbonate loss, one of the most useful measures is to look at the anion gap. The anion gap is a calculated difference between the total amount of cations in plasma and the total amount of anions in plasma measured in millimoles per liter, according to this equation. So it's essentially the combination of sodium and potassium less the combination of bicarbonate and chloride. Now, in vivo, there is no true ion gap. In order to maintain electrical equivalence, the cations and the anions must be equal. So the anion gap indicates the presence of an ion that is not actually measured in the chemistry panel, but that can be used to explain a low pH. So what you're seeing here on the left is the total cations, mainly comprising sodium in the extracellular fluid, with a small proportion of it contributed by potassium, and then a number of unmeasured cations, including calcium, magnesium, iron, zinc, and so on. Note that hydrogen itself is not actually calculated into the anion gap because it exists only in minute nanomolar amounts in blood. On the right-hand side of the screen, you're seeing the total anions in human blood. The chloride makes up the bulk of the measured anions, and followed by the bicarbonate. And the rest of the anions are contributed by things like phosphate, proteins, and a number of other organic anions. So the anion gap is the difference between this level, the unmeasured cations, and this level, the unmeasured anions. And this calculated gap is called the anion gap. And it is roughly equivalent to the charge contributed by plasma protein. So it's round about 16 plus or minus 4 milliequivalents per liter, depending on the specific reference range that your laboratory uses and how they calculate the exact anion gap. Now, it's quite common practice that because potassium is very low in extracellular fluid and actually varies relatively little, a lot of laboratory methods will exclude potassium from the calculation of the anion gap, bringing the anion gap down to 12, as you see here. So the equation in the blue is using standard midpoints of normal reference ranges to calculate the anion gap. Including potassium, it will be around about 16, excluding potassium, around about 12, plus or minus 4 millimoles per liter. Metabolic acidosis can present with a normal anion gap. On the left-hand side of the screen, we're seeing the normal acid-base homeostasis that we've just investigated on the previous slide, where a normal anion gap occurs because of a normal calculated difference between the unmeasured cations and the unmeasured anions in extracellular fluid. In the case of a metabolic acidosis with a normal anion gap, this difference between unmeasured cations and unmeasured anions remains the same. The acidosis on blood chemistry presents as a low bicarbonate, and because electroneutrality needs to be maintained, the bicarbonate that is lost is replaced in equimolar amounts in exchange for the lost bicarbonate, and this maintains the total anions in the extracellular fluid and therefore the normal anion gap. So the anion gap would be calculated according to this equation with a lower than expected bicarbonate level and a higher than expected chloride level, making the anion gap still calculate out as normal. So what are some of the causes of a metabolic acidosis that presents with a normal anion gap? The first one is a net bicarbonate loss. And as we've said before, this can occur through the gastrointestinal tract through a number of different mechanisms. Often severe diarrhea, particularly malabsorption type of diarrhea, chronic abuse of laxatives, pancreatic or duodenal fistula, where very alkaline gastrointestinal secretions are lost to the body. Other losses of proximal bile secretions, for example, drainage tubes that remove alkaline or bicarbonate-rich fluid. Ureter diversion surgery, including ileal conduits, can cause this form of acidosis by causing bicarbonate loss through the gastrointestinal tract. And then finally, certain drugs like calcium chloride, magnesium sulfate, and cholestyramine can also enhance the net loss of bicarbonate through the gastrointestinal tract. The second possibility is renal tubular dysfunction or renal tubular acidosis. And there are two particular presentations of this. Firstly, it can be a failure of the proximal tubules to resorb or reabsorb bicarbonate. And this can also be caused by chronic use of inhibitor drugs. Secondly, the mechanism can be a failure of distal tubule hydrogen ion secretion. And again, a number of drugs can cause this form of renal tubular acidosis. So how do you know if the deficit of the bicarb is from a GIT source or a renal source? Frequently, you will know from the medical and surgical history of the patient, but you also can use a tool called the urine anion gap to check that. So the urine anion gap, again, is a calculated anion gap calculated from urine sodium and urine potassium less the urine chloride, and positive values on the urine anion gap suggest that there is a renal cause. In other words, a failure to reclaim bicarbonate during acidemia by the kidneys. And a negative urine anion gap usually points to a GIT cause through losses of bicarbonate-rich fluid. The second potential reason for a metabolic acidosis with a normal anion gap is a reduced availability of bicarb. And this can be due to ingestion of substances which reduce that bicarb availability, including parenteral nutrition, or other substances which are metabolized to acids and therefore utilize bicarbonate buffers more than under normal physiological circumstances. A reduced availability of bicarb also is quite common in the resolving phase of ketoacidosis, for example, in diabetics who present in ketoacidosis crisis. And the effect is that there is a depletion of the bicarb used up in buffering an abnormal pH. The second possibility for causing a reduction in the availability of bicarb is an addition of a lot of chloride to the system, and this can occur with large volume normal saline resuscitation. So the excess chloride that is added to the system causes a shift of bicarb intracellularly, again to maintain the electroneutral balance, which removes bicarb from the extracellular fluid as a buffering system. So again, you will see on your blood chemistry a low bicarb level. The second presentation of metabolic acidosis is that of high anion gap acidosis. Again, on the left-hand side, we are seeing the normal situation with a normal anion gap. In metabolic acidosis with a high anion gap, there is a gain in one of various organic anions or acids that are added to the system or are generated in excess by the body system. As a result of this, the bicarbonate falls because it is used to buffer this excess acid in the system. And as a result, you have a high anion gap because the difference between the unmeasured cations and this increased level of unmeasured anions is higher than normal, called the high anion gap, as you see here. Let's look at some of the causes of high anion gap metabolic acidosis. The first common cause is ketosis, or an addition of ketones in the system. This frequently is due to uncontrolled diabetes, type 1 diabetes, or alcoholism, or a starvation state. All of these things lead to a mobilization of free fatty acids and therefore the production of ketoacids. And because these are organic acids, they reduce the pH of the system. Secondly, lactate, and also as a much rarer cause, D-lactate can cause acidosis in the system. The anaerobic metabolism that is associated with shock, for example, or low perfusion leads to the excess formation and reduced metabolism of lactate, frequently seen in shocked patients. On rare occasions, this can also occur as a secondary phenomenon to rhabdomyolysis. And then when we're talking about D-lactate, in short bowel patients, gut flora can act on unabsorbed carbohydrate to form D-lactate as a metabolic byproduct and some organic acids which when absorbed can lead to this form of metabolic acidosis. The third cause is chronic renal failure. So low glomerular filtration rate leads to a failure to normally excrete acid anions, and therefore they accumulate. And remember that phosphate also acts as an acidic anion under these circumstances. The fourth cause of high anion gap metabolic acidosis is toxins, and there are a number of toxins which are associated with this. These include methanol, various glycols, which are constituents of many intravenous drugs used in standard routine clinical practice, paraldehyde, paracetamol, salicylates, isoniazid, iron valproate. So a lot of different therapeutic agents can lead to metabolic acidosis in patients. If it is unclear which form of high anion gap metabolic acidosis has occurred, or if it's unclear from the clinical history which one of these could have occurred, it can be useful to do an osmolar gap calculation. It can help you to distinguish. So high osmolar gaps suggest toxins like methanol, glycols, also ketones and lactate, naturally occurring organic acids, or a uremic cause in a chronic renal failure type of a patient. Whereas a low osmolar gap suggests salicylates or paraldehyde, which is actually more rare these days. There are some ways in which anion gaps can be misinterpreted. Again, if we're looking at the normal anion gap or the normal unmeasured anion fractions, remember I said in the beginning that the anion gap is almost all due to serum proteins and a little bit of phosphate. The most abundant serum protein is obviously albumin. So if you have a scenario where the patient is hypoalbuminemic, this will reduce the anion gap, and it can be quite a substantial reduction, thought to be around 2.5 millimoles for every 10 gram per liter drop in albumin. So under these circumstances of hypoalbuminemia, a high anion gap metabolic acidosis may falsely appear to be a normal anion gap in patients who have low albumin, which we see often in the ICU. So it can confuse your interpretation of the anion gap or of the cause of the metabolic acidosis. So when you do have patients with very low albumins, it is recommended to do an adjusted anion gap calculation where the anion gap that you observe from laboratory values is adjusted according to this equation in order to account for the hypoalbuminemia. Mixed acidosis is actually very common, and you might want to know whether your patient actually has acidosis from more than one different cause, and exactly what those causes might be, or to help pinpoint the possible reasons for the acidosis. And the most useful tool for distinguishing different kinds of metabolic acidosis in a patient with a mixed scenario with multiple contributing clinical factors is to look at the delta ratio. The delta ratio is the change, which means the increase, in the anion gap as a proportion of the change or the reduction in the serum bicarbonate level. So you're basically answering the question, is the decrease in bicarbonate greater or less than the rise in the anion gap that I'm seeing? So a delta ratio of different levels can help you distinguish mixed acidosis. So a delta ratio of less than 0.4 is what you classically see in normal anion gap acidosis, also called hypochloremic acidosis. A delta ratio of between 0.8 and 2 is classically the high anion gap type of acidosis. But in between these levels, a delta ratio of 0.4 to 0.8 suggests a mixed type of acidosis, a mixed normal and high anion gap acidosis. And delta ratios of over 2 are due to usually a mixed high anion gap acidosis plus a metabolic alkalosis, or occasionally a chronic respiratory acidosis, so that there is another cause of abnormally high bicarb levels, which changes the interpretation of the metabolic acidosis. Now, there are always compensation mechanisms. When you have a primary acid-base disturbance like a metabolic acidosis, there will be a secondary compensation that occurs over a period of time. It is not immediate, and it partially counteracts the impact of the original acid-base disorder. So it attempts to correct the primary disturbance, and therefore the compensatory process always opposes the original acid-base disturbance. So in metabolic acidosis, that is your primary your primary acid-base abnormality, the characteristic feature is low bicarbonate levels, because bicarbonate is used to buffer the increased hydrogen ion activity. The compensatory mechanism for metabolic acidosis is respiratory hyperventilation response, which reduces the PCO2 level. And PCO2 levels will follow the direction of the bicarb. So when bicarb falls, PCO2 levels will fall as part of the compensation. So let's look at it in a timeline. You have a scenario which causes metabolic acidosis, one of the ones we've discussed. This stimulates central nervous system and vascular receptors and causes an increase in the respiratory rate, leading to a hyperventilation response, which reduces carbon dioxide levels and therefore reduces the carbonic acid level of the blood, and which compensates for the fall in pH and attempts to raise the pH level. So when you look at the biochemistry, depending on at what stage of the clinical process you are seeing the patient, you might be able to detect that compensation mechanisms are occurring. So in a patient with metabolic acidosis who is completely uncompensated, what you will see is a low pH, classically low bicarbonate levels, and a normal PCO2. A patient who has started the respiratory compensation process will still have a low pH and a low bicarbonate level, but their PCO2 will already have started falling as part of the respiratory hyperventilation response. A patient who over time has fully compensated for the underlying metabolic acidosis will have a pH that is restored to normal, but the bicarb will still be low and the PCO2 will still be low, because those are the buffering systems that have been used to correct the pH. Please check out the website criticalpoint.co.za to find this metabolic acidosis algorithm and other useful clinical practice tools.